Health system partnerships are the springboard for growth at Medical Service Company. Our collaborative approach with these partners ensures we understand their current initiatives, challenges, and opportunities so we can achieve progress together. Regular business reviews where we can share data and best practices creates an environment of trust and transparency that all types of partnerships must be built upon. Health systems continue to adjust their care delivery models to reach more patients at home, and many are forging partnerships to help meet increased patient demand for these services. As we consider the entire care continuum, home medical equipment companies play such a vital role in the patient's outcome once they leave the hospital. We are the eyes and ears for the providers in the patient's home, and our team of highly trained professionals are standing by to help. Medical Service Company greatly values our health system partnerships. We take great pride in assisting our partners in preventing avoidable readmissions, decreasing hospital length of stay, and increasing patient satisfaction. If you would like to learn more about how we can work together to achieve these results, please visit medicalserviceco.com to learn more.
Continuing on today with our sleep and respiratory lectures, I have the privilege of introducing our next speaker, Dr. Kingman Strohl. Dr. Strohl currently holds multiple professional appointments and positions. He is the director of the Center for Sleep Disorders Research at Lewis Stokes Cleveland VA Medical Center, Program Director for the Case Fellowship in Sleep Medicine at Case Western Reserve University, Professor of Physiology and Biophysics, as well as Professor of Oncology at Case Western Reserve University. He is a Professor of Medicine at Case Western Reserve University School of Medicine, where he has held tenure since 1988. Dr. Strohl also acts as Fellow for the Institute for the Science of Organs at Case Western Reserve University and Staff Physician for the Department of Medicine at University Hospitals of Cleveland and VA Medical Center in Cleveland, Ohio. Dr. Strohl has been co-author on over 48 medical journal publications and has written book chapters for reviews for over 25 textbooks. In today's lecture, Dr. Strohl will be covering mechanisms for treatment of OSA. If you have any questions for Dr. Strohl, submit them through the Engage tab to be answered during the live Q&A portion of our lecture. To receive credit for your attendance, please be sure to complete the survey following the presentation. We hope you enjoy this lecture.
Hi, good morning. I'm Kingman Strohl, and I'm going to be talking to you about mechanisms of OSA therapy. That's the treatments that we use for obstructive sleep apnea. I want to be able to sort of tell you I have some disclosures that are relevant. Those are symmetrics. I'm a PI for the Air Sleep Super trial. I'm also just started out with the apneas site, which is a drug trial for OSA. 7 Dreamers, I've been a consultant for. It's an airway stent. And Animed, which is an oral appliance that's going on here. It's a locally engineered appliance. Now, I'm not going to be talking about them. They're not FDA approved, but I'm going to be talking about the principles of why these things work, and I may illustrate them as principles. So why do we treat sleep apnea? Well, here's a sort of a graph of what is the illnesses that are associated with untreated sleep apnea, obstructive sleep apnea. And stroke is the highest one that we know about. Death, of course, with severe OSA, it's very severe. Then hypertension, motor vehicle accidents, heart failure, occupational accidents, type 2 diabetes, death from moderate OSA, and depression, coronary artery disease. So the estimates are there's about 900 million worldwide. So these are people with various levels of severity, but the treatments may be indicated for maybe as much as about half of those people, and we need to be able to figure out how to do it in an efficient manner. The apnea types I will be talking about will be obstructive and mixed, but these are for those that sort of want to know what these definitions are. A central is also called a non-obstructive apnea. That is, there's a cessation of airflow in nose and mouth, but there are no efforts. no attempt to breathe. Obstructive is that there's no airflow at the nose and mouth, but there are efforts. And something called a mixed apnea is a combination of a central or non-obstructive part of it and then an obstructive part of it. And in all of these, there's a reduction in oxygen saturation, and there often is an arousal or interrupted sleep at the end of it to be able to restore breathing. There are subtypes that we define: flow-limited breaths, hypopneas, RERAs, which are respiratory effort-related arousals. But we're going to really try to think about these obstructive and mixed apneas and how we might treat them. So one of the pretest probabilities is called the stop-bang. Snore, tired, observed apneas, pressure, hypertension, BMI, body mass index, age, and gender. And they have it, 1 to 8 to each point. And I think we kind of think about what makes up recurrent apneas, and the higher the number, the greater the chance you have. So the anatomy is sort of captured by the BMI, and you can sometimes do neck circumference. The symptoms of snoring and tired and apneas sort of tell you whether or not there are consequences to the apnea, as does hypertension. There's the age, demographics, male or female. That seems to be important. But then obviously there's other things that we take into account, like head form, malampati, which is the crowding of the upper airway, family history, and whether the bed partner is annoyed by the snoring. Now, whether that brings the patient into the hospital or whether their bed partner brings them into the hospital or the examining room, we'll just sort of say that they make a loud noise. So the objectives of this talk are to describe the pathophysiologic traits for sleep-disordered breathing and apply these concepts to the current therapy. Now, you'll notice here that there are none of those features in the stop-bang. The stop-bang is a pretest probability for having sleep apnea. The stop-bang is done during wakefulness, whereas sleep apnea occurs during sleep. And the causal pathways to recurrent obstructive sleep apnea include an anatomy, a small collapsible airway, loop gain, an oversensitive ventilatory control system, a poor muscle response in either the gain or reaction of the muscle to obstruction. And then, of course, it has to be called sleep apnea. So do you go to sleep? Do you wake up? And these give you multiple obstructive sleep apnea. We'll talk about these particular features first. So here's an example of a patient breathing during sleep. And I don't think we organized to get the sound here, so I'll try to kind of tell you what's going on. And this guy initially is not making any sound, but you notice he's rocking and trying to breathe. Now he breathes. He's making a snore, one breath, and then he stops again. And then he starts to breathe again, but he's making these obstructed breaths, You don't make any sound here. Even though his mouth looks like it's opening, he's closed at the nasopharynx. And now he takes one breath, takes two breaths. He takes, doesn't take a third breath. He takes an obstructed breath and he stops breathing. That's the non-obstructive part of this particular apnea, and then starts up again. And this goes on, in this instance, this goes on for about 40 times an hour, especially on his back. So this is severe obstructive apnea, and there are mixed apneas in with that. Now, here's the electrophysiology of that event. On the top are the EEG, EOG, submental EMG, EKG, oxygen saturation, airflow, tidal volume. Esophageal pressure as a measure of effort and respiratory size, and then a microphone. But the thing to notice is that this is the end of an apnea. There's an activation, there's an arousal, there's 1, 2, 3, 4, 5 breaths, and then you go into another obstruction. And then at the end of the obstruction, there's a snort, and this thing opens up, and 1, 2, 3, 4, 5 breaths. But I want to make a couple points. First is that this apnea is occurring with the cessation of breathing at the airflow, nose and mouth, but you notice the esophageal pressure swings are still occurring. The other thing to notice is that these are terminated by an arousal, that is a awakening from sleep, and then a restoration into sleep. At the end of an apnea, there's increasing efforts, which makes that large snort and snore occur. But at the beginning of the apnea, there's a reduction in drive. And that reduction in drive is important because if this airway is collapsible and there's a reduction in drive, it'll collapse like it did here. But if this airway is not collapsible, it's going to cause a non-obstructive apnea. And this will come back to this theme. So it's called the critical closing pressure. That is what makes this airway close. And this is a study which used CPAP machines and did various levels of putting a nasal mask on a person and positive pressure for obstructive sleep apnea, or for normal people or snorers, you create a negative pressure at the nose. I can create obstructive sleep apnea in anybody by putting negative pressure at the nose. And what you'll see is that the pressure range here is from about minus 12 to about plus 4. We know that sleep apnea needs plus 4, plus 8, plus 15 centimeters of water to open the airway. But if you take a person who's healthy, you have to close it with negative 12 centimeters of water. You have to suck on the airway and close it. But there's a gradation between normal snoring, upper airway resistance syndrome, obstructive hypopneas, and obstructive apneas. And what's interesting is that you can anesthetize these people, you can paralyze these people, and look at peak crit, and the normal people are about at minus 4. And the mild and moderate are higher, they're above 0. That is, you'd have to have something to open the airway. But what's really quite interesting is that this effect of anesthesia and muscle paralysis shows that there's some sort of active neuromuscular mechanism in healthy people that keeps the airway open. That's the neuromuscular force that somehow is not working very well in the presence of obstructive sleep apnea. The second point is that the critical closing pressure under anesthesia is not much different from the critical closing pressure. A person is not anesthetized and not under neuromuscular blockade. So the mechanical load and the neuromuscular responses are important for keeping this airway open. And the peak crit here, the critical closing pressure, is a balance of forces between the compensatory neuromuscular responses and the mechanical load. This mechanical load can be obesity, it can be problems in the airway itself, it can be fat neck, it can be other things, but these are the things that produce this closing of the airway, which is the critical closing pressure. This critical closing pressure is called peak crit. Mentioned it before, and normal people have a neuromuscular activity during sleep that keeps it open, and people who have snoring and obstructive apneas have what they call a positive peak crit. Peak crit is important. Anatomy is important in everyone, but this is a fairly recent observation that on the vertical axis, you have the critical closing pressure from -20 to +10. And on this axis, the horizontal axis, is the number of apneas, apnea-hypopnea index, 0 to 120. And what you see is that if you takes a sucking pressure to close that airway, you rarely have obstructive apneas until it gets to be about -5. And then if it's above like -1, you always sort of have some degree of apnea. And in between, you may or may not. It's a vulnerable airway. That's what we call it. But if you had a peak crit here of, say, +2, you could have an apnea-hypopnea index of 15, or you could have it almost out here to 100 to 120. So peak crit, anatomy is important to everyone, but anatomy is not the only particular issue that gives you recurrent obstructive apnea. So the next is, this is an example of recurrent apneas. And this is a recording I made in 1978, oxygen saturation, gene and glossal EMG, rib cage abdominal motion, airflow of the nose and mouth. This is the apnea. This is the mixed apnea, but I want you to focus on the beginning of this apnea. There's a reduction in gene glossal EMG. And then each of these apneas, if it goes into a central or non-obstructive part or an obstructive part, that it does so in the context of a reduction in drive to upper airway muscles. So the recurrent falls in drive really do produce this obstruction. But what then makes you have another apnea? So this is called loop gain. It's been around for a while. People kind of get their head wrapped around it as being some sort of special term. But it's in feedback. It's the lag and rise. It's the tendency for ventilation to return to an equilibrium point. It's a tendency for your car to get back on the track if you dodge a rock in the road. It has two components. One, the controller gain, that is how your brainstem works, and how your plant gain, that is how your upper airway and your lungs work. And so this loop gain is an old concept, but it's important because it tells you really what happens. You have more apneas. Now, if you take a person with obstructive sleep apnea and give them a little bit of CPAP, as it was done here with +3, you turned all their apneas into non-obstructive apneas because the airway didn't close anymore. It was not unstable. But the unstable breathing are these recurrent central apneas. And so this recurrence is the important thing to multiply apneas over time and to get from that 15 apneas an hour to 100 apneas an hour. There's some other features. Loop gain is higher in OSA, so breathing is more variable. That's been shown now for a while. And the upper airway stability itself occurs at the low time of motor output. So your upper airway resistance increases as your ventilatory motor output reduces, and it does so in a sinusoidal fashion to give you apnea after apnea after apnea, which I sort of showed you in that example of the patient. So the pathways to recurrent apneas that we think about now are anatomy, First of all, let's go sleep. Let's get people to sleep. That's the first thing. First, it's sleep. It's not called wake apnea. It's called sleep apnea. You got to put people to sleep, then they wake up, they go back to sleep, wake up and go back to sleep. Anatomy. You got to close that airway. You have to, or you keep it open. Doesn't matter, but to get obstructive apnea, it has to be collapsible. You have these other two things, which are called loop gain, which we've talked about, and these poor muscle response. So I've told you this example again. One starts with anatomy, knowing that gain, muscle, and reflex and arousal threshold can propagate apneas over time. So the next goal in the next 5 to 10 years is to have a sleep study or have a test or have a way of predicting which pathway could be the one that we should hit first. Obviously, PCRIT and the anatomic pathway is important, but can we also hit other pathways as well? So the goals of treatment are to maintain upper airway patency, restore sleep continuity, retain adequate gas exchange, improve quality of life, sleepiness, neurocognitive function, and lower diurnal blood pressure and decrease all-cause mortality. Well, I don't care how you do it. Those are the goals. But now we have to figure out what the methods are. And we're going to go through a kind of a Mr. Toad's wild ride of all the therapy that we have, and really to be able to figure out what is the principle of those therapies. So what is it? Where does it work? Tracheostomy. There we go. It bypasses the whole problem. It's a cure at about 88, 83%. Sleepiness resolves in a lot of people, but it has psychosocial problems, local granulation, recurrent bronchitis. Now, Nastent. I told you that I was a consultant for these. This is sold in Japan and in Europe. It's a little flexible tube that you put through your nose to the back of your palate, and you can breathe through that, and it opens your airway. You put it in every night. You get one that works for maybe 2-3 nights, and it bypasses the whole thing. So, that's one thing you can do. It's not something that either myself or most of my patients take to like a duck takes to water, but it's something that people have used to try to treat their sleep apnea when they don't want to use other therapies. So CPAP has been our go-to therapy, described in '79, doesn't care where it dilates the airway. It uses a pressure stent of a positive pressure, and it increases functional residual capacity. And the two pictures on the bottom show that there's an increase in the size of the airway, and the narrowing occurs on a much shorter basis behind the tongue. So nasal CPAP, it doesn't care, it just airway splint. In fact, people have talked about it as being, it's like a air pressure intubation of the upper to the trachea in people during sleep. The effect can be miraculous. This is quite severe OSA on the top for one night, and the next night they put 12 centimeters of water on, and the hypoxemia, which is dropping on the top to somewhere below 70 on a recurrent basis, now is all above 94%. So this is useful. This works. It works as a pneumatic splint. It passively opens the airway. It doesn't activate anything. It doesn't do anything kind of strange. And if you stop it abruptly, the EMG activity doesn't come back very quickly. It's a passive airway. It's on the right, shown in studies that we did in '83. Nasal pressure is abruptly dropped, and you have immediately two things happen. One, an obstructed upper airway, and also you notice the abdominal FRC falls as well. So the targets are collapsible airway, gain. Gain is improved with CPAP. It has a larger lung volume. Muscle response not relevant. And the arousal threshold, a low one may interfere with acceptance. That is, if you're bothered by something on your face or you're bothered by small events or things of that sort, that gets in the way. But the CPAP targets are primarily the small collapsible airway. Its acceptance rate, though, is about 50%. 40% of people take to it like a duck takes to water. Another 20, 30% you can work with. And I think that's pretty good. And that may be an underestimate with the newer equipment we have. So we use an oral appliance. Now, there are tons of oral appliances. That's the other one. Tongue advancement, mandibular advancement, adjusted, fixed, customized, boiled, bite, new ones we're working on. It drops the peak crit by about 4 to 10 to 11 centimeters of water. And you notice that range there of you might not have sleep apnea if you get down to a -4 or 5 peak crit, that you can get that, +3 down to -5, and you can treat that sleep apnea using an oral appliance. Oral appliance increases the size of not only back of the tongue, it also increases the nasopharynx. It keeps the stability of the nasopharynx there. On the left is before, and on the right is during a oral appliance. Incremental mandibular advancement can improve pharyngeal mechanics and oxygenation. And in the example here, control, you have an oral appliance. It's set at the same kind of place that a person usually puts their lower jaw, and then you increase it by 2 millimeters, 4 millimeters, or 6 millimeters. And it's impressive. Each 2 millimeters improved AHI 20%. In this example, obese less effective than non-obese, but still works. But its outcome is not well predicted by AHI. Problem is, it's something you put in your mouth, has to be fitted by a dentist. Everybody says it's cheaper than CPAP, but really with all the ups and extras of visits, it may or may not be that too much different. On the other hand, if you wear it, it's a lot better than if you don't wear CPAP. So it's important. Oral appliances are indicated for mild and moderate. There are some people that prefer oral appliances to CPAP and do not respond or fail to CPAP, or not appropriate candidates for CPAP because of some sort of problem in their upper face. Not as effective on CPAP on AHI, but if you use it more often, it's important, and it can lower blood pressure. And in one head-to-head, it outperforms surgery. That's interesting. So surgical therapy is the next thing you think about. Size and compliance. Surgical targets, small collapsible airway. Does it hit the control system? No. Does it hit for muscle response? No. Does it change arousal threshold? No. So it's taken a bet. It's taken a bet. There are many surgical approaches. The uveal palatopharyngoplasty, which was in the 80s and 90s and earlier this century, has now given way to the lateral wall stabilization approaches, version 1 through version 6. And across the country, you have to really ask these surgeons how they're going to do it. They do it according to how they were trained. Certain places, West Coast does it a little different from the East Coast, that does it differently from the Midwest. Unfortunately, they don't have a lot of multi-center trials, although they're trying to do that. And then the other is other approaches that go towards what looks big, I'm going to make it smaller. What looks short, I'm going to make it longer. Those sorts of approaches, tracheostomy being one. There are no peak-crit measures, although I think they're starting to do it, of measures before and after these surgeries. Not as predictable or as durable or as generalizable as one would want. It can be effective, though. This is watchful waiting versus surgical group with a uveopalatal and some people got into a range, even those that were sometimes pretty big. So the optimistic surgeon can say, well, 60% chance of reducing your AHI to below 20 or at least by half. And but watchful waiting does it by about 11%, because things vary over time. There's not just the upper airway that determines your number of apneas. Mandibular maxillary advancement is you take the midface and the jaw, break them, and you move them forward. And carefully selected patients have good success rates. But it has a lot of rehabilitation. No measures of peak crit yet. More predictable and perhaps generalizable, but in part because of recent use of pre-surgical planning tools. And there are a few people that can do this in the country on a reliable basis. Can loop gain be targeted? Well, turns out to be loop gain might be able to do this. And this is then the sorts of things that you can do and reduce apneas if you reduce loop gain. Weight loss is important, and that may be loop gain may be the issue for what happens with surgery as well. But weight loss, modest weight loss is important. Bariatric surgery is important. Anatomy, peak crit is reduced. Medical and bariatric weight loss, including the use of the newer diabetes agents, gain can be increased because of increased oxygen stores and the sleep. There are less state changes. So it looks like obesity is a way that we should, especially with the newer treatments and the newer approaches, are likely to do good things for this particular sleep apnea. Nasal expiratory PAP, that is, putting something in your nose that it's hard to breathe out, so the pressure goes up during expiration, and then you breathe in with a more open airway. Provent is no longer available. The bongo therapy is there. There's UltraPAP out of Cleveland. And this is trying to lower the peak crit at the beginning of inspiration so that you can take a good breath. There are differences among these devices and their ability to create a back pressure, and that this is important to know. And these are not first-line therapy. These are for people that may not, or that have mild disease that also has a few apneas that can wear something on their nose. It takes getting used to, because it's you need to learn how to fall asleep with your mouth open and then allow your mouth to close and you breathe through your nose. But there are some people that this has really been a fantastic alternative to CPAP. And really that just reminds you, you just don't have to you don't have to decrease the peak crit very much, maybe 2 centimeters of water. All right, current state of EPAP, those with mild to moderate, takes time and explanation of sensation, and payment is out of pocket. Other little thingies, positional therapy. That's important for people who have very few apneas on their side, but have a lot on their back. There's actually a device that says if you're on your back, it'll tell you you're on your back. It tries to train you. The winks and the INAP are ones that try to suck the tongue forward. And CNAP, the negative pressure around the neck, is a method to try to open the airway from the outside by producing a negative pressure around the neck. It can work in certain people. This is a very preliminary study. This particular approach is being looked at in an FDA phase 3 trial. It's not available at all for purchase, but that this is an interesting way that not only can you pressurize the airway by CPAP, but you can pressurize it by changing the peak crit around it by negative pressure. The anatomy is improved, and it is interestingly improved almost as much as 10 centimeters of water. Can open both the retrolingual and the retropalatal space. So this is the recurrence idea. Can we target these changes in EMG activity that occur at the onset of an apnea? This is muscles in the airway. That is, what do muscles do? Well, I've shown you a peak crit, that is a passive peak crit. But if I have muscle activation, I can move it to the left. I can improve that peak crit. And this is an example of how EMG activity in the genioglossus falls, and you set the start of an apnea. If I could keep this activity open in both tonic and phasic activity, maybe I can prevent an apnea. So, neurostimulation. There we go. We better living through electricity. We can activate that nerve, even if you don't want it to be activated during sleep. And so that we hit the hypoglossal nerve is the general one that people have worked on. Maybe not be the only thing to work on, but that's what things have. There's a first proof of principle in 1993, and Inspire 2014 got FDA approval for their version of neurostimulation. Does it work? Yeah, this is an example using Inspire of 1, 2, 3, 4 apneas. You turn it on, and it's a continuous tracing. And after a little bit of uncertainty in breathing, actually that's loop gain, it becomes pretty regular. There's a little bit of flow limitation that may be occurring, but people use it, and it immediately stabilizes the airway, ideally leaving all the other pathways alone. It can work. This is the palate with the therapy off. Here's the tongue base with the therapy off. And here's the palate with the therapy on. And here's the tongue base with the therapy on. And it opens this thing up. And it really kind of restores this. It has a fairly powerful effect. It produces about 40 to 60% of the maximal force. But you can sleep with it. It's stimulating the nerve does not wake you up. Other neurostimulation is down the pike. The apnix therapy study, which was done, stopped in 2015 because it didn't think it would pass muster. But the Osprey study is enrolling now, And that's currently, these are both implantable devices. And just recently, there has been a report of an injectable. That is, you don't have to do open surgery or stitches, but you can inject a stimulator around the hypoglossal nerve, and or at least at the insertion of the hypoglossal nerve into the tongue. I've not seen that. Don't have any experience with that. But but stay tuned. Finally, I want to go into two things: myofunctional exercises. Myofunctional is training to get rid of disordered habits and replace them with proper habit. It was first described in 1918 to improve retronathia. And this is a recent myofunctional therapy for retronathia of someone who went through the therapy, and you can see that the lower jaw seems to move out and seems to change that profile beneficially, in a beneficial fashion. Myofunctional therapy came about with playing a musical instrument. Oboes and bassoons don't have as much reported sleep apnea treatments. Didgeridoo playing improves sleepiness in AHI. But the evidence for myofunctional therapy is that there are seven case series, seems to improve it, decreases relapses in pediatric OSA adenotonsillectomy. The mechanistic evidence is not as clear as you would want. I just would want to show that there is a study of 7 exercises that show that it can reduce AHI from about 23 down to about 14, whereas placebo time control goes from the same value and stays about the same. What is it? Well, there are 7 exercises. I'll just show you one of them. One is, brushing your tongue with a toothbrush. Another is putting your tongue in the side of your mouth. There's a whole series of things happening, and it's trying to get the back of your tongue and the back of your throat, training those muscles. So this particular list of exercises, that's an interesting one. You do for about 20 minutes a day for 10 weeks, and it improves your snoring and your apneas. All right. Are these formal regimens necessary? Well, some people have done expiratory muscle training and then these instruments as well. So pharmacology targets are loop gain now and mechanical interactions. I'm going to briefly go through these drugs, and I'm going to go through their rationale, how they would find. But if you could drop P-crit with a drug, or you could drop loop gain with a drug, you could see if you could reduce sleep apnea. So druggable pathways include oxygen, cetazolamide, buspirone for loop gain, trazodone, and sleeping aid for trying to keep people asleep and allow the muscles to increase their activity. But poor muscle responses, upper airway stimulation, muscle training, and now drugs. This is a very new, there's no FDA drug available for this yet. They're in trials, but I'll just briefly tell you how it was found or how it was looked at, because in the 80s, 90s, there were a lot of trials of drugs that did not work. So what ended up is the genioglossus became a target. May not be the only thing that's important. The Horner Laboratory in Toronto created a map of gene expression arrays looking for differential expression of ion channels, G protein coupled receptors, and other markers. They published this thing, and what they could found is cannabinoids were things that were available that would hit these receptors on the hypoglossal nerve. Muscarinic receptors were there, and also adrenergic receptors. And so there are a couple groups then went out and looked at different areas of this. What's interesting is a mondoxidine and oxybutynin, which is a norepinephrine reuptake inhibitor, and a muscarinic. These are available and can be they can be prescribed, but they're particular amounts and what they do are well known, but they haven't been used for obstructive sleep apnea. And what you see is that both of them together seem to drop people from an average AHI of 32 down to almost 5, but neither of them alone, and that's because they each target non-REM and REM mechanisms for the fall and genioglosal EMG activity. So this is the example of, and this is now in phase 3 trials. This seems to increase the gain of the upper airway muscles, which you can see the genioglossus gain can be measured. And this is placebo gain during an apnea. This is anti-oxy increase in gain. So it increases EMG activity. And we have 2 lines now of medicinal chemistry. One is this norepinephrine agonist for non-REM stability, and the other is the cholinergic inhibitor for REM stability, REM stability. The other one is Tramadol, which has been used as a pain relief for, it's a cannabinoid, and with or without acetazolamide. That's going into trials as well. So individualized therapy will require integrated mechanistic assessments for PCRIT, muscle action, sleep effects, ventilatory control. We don't have any gene sort of therapy for this. It's a complex disorder. No one gene produces it, and it comes over time. And so the pathways of therapy for recurrent OSA are going to be what we have here. I think, let me go back to the first one here. That's what we usually use: CPAP, oral appliance, Provent, Winks. Oxygen, acetazolamide may help even in obstructive apneas. Poor muscle response, sleep-wake mechanisms may be able to keep things asleep, and poor muscle response with what I've talked about. So in summary, obstructive sleep apnea is a state-related disorder with sleep. It's caused by an abnormal anatomy. It's a reduced muscular activation. And to make a lot of apneas, you have to have a high loop gain. The current targets are anatomy, and the aspirational ones are the drugs that use muscle activation, but we have hypoglossal nerve stimulation as a bridge. I want to thank you very much. These are the objectives that I wanted to approach, and I wanted to be able to kind of explain what to look for in newer therapies that come in the future.
Hello, everyone. Leo Nizzi here from Medical Service Company, bringing an end to the combined respiratory sleep track with Dr. Strohl. Thank you so much for closing us out on a fantastic morning section. I know you have some prior obligations to get to, so we're going to do our absolute best to get you out of here, but I know there was a lot to unpack in that presentation, so thank you for putting so much work into it. So we'll jump right into the Q&A for you.
Yeah, they can always contact me if they have other specific questions as well through University Hospital's email or kpstroll@aol.com. So.
Oh, wonderful. Thank you for making yourself available.
So what do you got?
Yeah, let's jump right into it. So first question for you, Dr. Strohl, is are there any updates from Inspire in terms of effectiveness, any studies showing efficacy of Inspire combined with optimizing nasal airway versus not?
So Inspire has been here since 2014. I've been told that there are probably more than 25 1,000 implants done worldwide or done mostly in the United States and Europe. So it's really a commodity now. Now, being a commodity means that there's a lot of training, there's a lot of push to it, there's direct to consumer. In general, if you pay a lot of attention to the patient characteristics that imply that they will have a good outcome, and they do that a lot in Germany and in Europe, the success rates are fairly strong and somewhat improbable. I mean, more than 80%, 85%. But I think in most places, especially now that it's in people who don't have as much training in either sleep medicine uh, or in the management of these things, it's probably more like 65, 70%. Now, a lot of people feel better. Just remember, there's a big demand for this, and people really don't know what it is in these direct to consumer. So you have to be careful, and the surgeon has to be fairly uh, knowledgeable and interactive with their sleep medicine providers to know that snoring and sleepiness may be true and unrelated because of sleep deprivation, other sleepiness syndromes. And so I think that that's really the big challenge, and the company knows this, and the training will proceed. But I think that when it becomes sort of expected, then it's not. There can be a lot of mischief in it. Now it is expensive, so the insurance companies will also be involved, but it's not for everybody. And I talk many or more people out of it than I do put forward to the ear, nose, and throat person to evaluate. And of that group, maybe as much as 4 out of 10 that I refer really meet the criteria and really understand what's going to be going on. But on the other hand, the evaluation of the patient who doesn't accept CPAP for ENT, including a DICE, may be important for looking at other therapeutic modalities. In Europe, for instance, they do DICE for oral appliances in certain people.
Yeah, no, makes sense. I'm sure the television commercials about the Inspire don't help the cause at all. Probably really increasing that patient population that really wants that device.
I like the interest, but the other side of it is really we have to pay attention to how we offer, introduce, deliver CPAP, because in order to be eligible for Inspire, you have to be CPAP intolerant, and if people really have not been taught or instructed or not fitted for the right equipment, or alternatively they tried it 10 years ago and haven't tried it recently, we need to make sure that they know that there's opportunities. I mean, putting it on at night for your Inspire therapy and turning it off in the morning, what is it? Takes you 8 minutes to kind of get ready, and then it turns on when you go to sleep, and you turn it off when you wake up. Well, you put on your CPAP for 10 minutes, and you wake up and take it off at 3 minutes. That means you only wore it for 13 minutes because you were asleep the rest of the time. So I think there's a way you have to present that to these people. All right.
Sure. Yeah, and I can appreciate that. Thank you for elaborating. So I know, in the interest of time for you, we'll throw one more question out there. Do you have any opinion on the new Excite OSA device, its efficacy, and what type of patients it would be most appropriate for?
So I think the Excite device is directed at this myofunctional therapy. It's done during wakefulness. It's presented to the patient as a device that they put below their tongue, and they are to try to activate the muscles not only of the genioglossus but the geniohyoid. It puts an electrical current in there, and there's a gradation up to it, and it takes some time. I mean, I think it's 6, 8, 10 weeks, and it's almost every day you have to sort of work on this. And it has some clinical trial data. I think what you have to realize is that exercising your tongue is sort of like exercise in general. You have to be able to be committed to it. It has to be something you want to do. It has some other things that they caution about. For instance, You will have a salivary response, so it's not something you can do in a conference room. Uh, it's it's also if you have fillings and you don't put it exactly right, it'll tell you got a filling because it's an electrical current. And I think but those things are just like every other therapy that we try as an alternative to CPAP.
Mm-hmm.
Now, how does it? The basic issue is what is it doing and how is it opening up your multi-site obstruction of your upper airway? And so that's always been the interesting thing of unilateral hypoglossal nerve stimulation is that it opens up your nasopharynx, and therefore it makes you breathe better. So does excite actually engage those other muscles? Now, I as a thought experiment, if you put your tongue between your teeth and swallow, you'll realize that you have muscles back there in your posterior palate that you never knew you had. Now, the other thing I'll tell you is do it 3 times and you can't because you're just not used to coordinating all those muscles. Yet you use all those for speech, swallowing, hiccups, all sorts of stuff. So we got a lot to learn about myofunctional therapy. What's the best approach? How can you do it? And I think throwing the kitchen sink at it is okay, but we need to figure out the basic science, not the basic science, but the practical human functional science. That means that we know that it works because then we can target certain areas and really understand more about the upper airway. I don't know, if you got a burr in your saddle. So right now my burr in my saddle is to define upper airway sleep health. That is, if there are 6 billion people in the world that have OSA, there are 5 to 6 billion people that don't. So why don't they have it? So that's what I challenge everybody. Why don't they have sleep apnea? And those people, especially children that grow out of snoring or don't snore or have things. So we're trying to kind of figure out with experimental as well as basic science. The glossopharyngeal nerve, the ninth cranial nerve developed, the 12th cranial nerve developed last. And it's for packing food into your gullet. It's not for keeping your airway open. So there you go. There's a wild idea there.
Well, I can definitely tell that your other little things slide definitely sparks some interest in these new therapies that are going on. So again, Dr. Strohl, thank you so much for spending some time with us today, for supporting the Gene S. Marx CEU event, and of course, thank you for supporting your patients and sleep and respiratory in general. So have a great rest of your day, and thank you again for bringing the combined track to a close.
Okay, thank you, and sleep well and have a better tomorrow. How about that?
Thank
All
you.
right.
Take care,
See you
doctor.
later. Good.